All right, great. Great. Thank you so much, Dr. Christensen. So we're going to get everybody else back here kind of around the table and to kind of run through our questions that have come in through the Q&A box and kind of answer, the questions that people have. So let me kind of run through this. So let me see here. So we have a question here for Dr. Dewan. So why is it hard to bring gene editing into NF1 and NF2 in human trials? Is it funding or is it problems with the gene itself?
Absolutely. So thank you for the question. That's a fantastic question. So there's a few things that make it hard. One is this is just very new, right? So it just hasn't been done yet. And the other part is we need animal models to be sure that what we're doing is safe. Animal models in NF1 have come a long way in the last 5 years, but there's still very few that we actually have. And it takes months to years of work to develop animal models right now. There are initiatives that my lab and others are working with to actually accelerate that so we can accelerate the progress in this disease. The second bit is that every patient or many patients have very different genetic changes. And so the treatments have to be specific to that. And then some patients, we can't even find the genetic change in NF1, but they have the clinical syndrome. And in those patients, I think it will take much longer to bring genetic therapies. But certainly there are a few roadblocks, but we're actively working to help make those a thing of the past.
Okay, thank you. The next question was about a neuroma on the left hip for several years. Early this year, I noticed that it was increasing in size, but it has now gone the opposite way, is almost gone. Can that really happen? Can the neuromas go away without medical treatment? And so,
That's an interesting question, but there was a study at Yale. They looked at 50 individuals with neurofibromatosis type 1, and they followed them, I think, for 25 or 30 years with a whole body MRI. And there is a clear change in the natural history of these neurofibromas as we transition from pediatric to adults in terms of rate of growth. Some tumors did, in fact, regress spontaneously without any intervention. We also see this in optic nerve glioma. Some of them, once we transition from pediatric to adults, they can spontaneously regress, but not to the point of to be totally gone. Sometimes the tissue around it, if we lose weight, gain weight, these weight changes can make certain tumors more noticeable or less noticeable. But it's important to highlight, as Dr. Patel presented earlier, as Dr. Megan Jack also mentioned, we worry about the rate of growth in adult if a tumor is actually growing fast, because that can be an early signs of a benign tumor trying to turn more aggressive or to be cancerous. So it's very important to bring this up to your provider just to make sure that there is no concern about malignant transformation. But great question. Thank you.
and the next question here for Dr. Tonka, are you aware about any pain medicine clinical trials in neurofibromatosis? Anything in particular in the field there?
Nothing specific, but going back to that topic of hope, as you know, most of the medications we currently use for pain management are 20, 30, 40 years old. They've been grandfathered into the uses we want. Currently, there are, I believe, at least 24 different clinical trials in varying stages of new novel medications for pain. And so while I'm not familiar with any specifically for NF, just statistically, I think we should be in a much better place, hopefully by the next couple of years, definitely by the end of the decade when it comes to chronic pain management. We're making huge strides in new novel approaches.
Great, thank you. Next question, has there been any research with a link with NF1 and autism? Yeah, let me answer that one. That one's tough. Definitely with NF1, at least 50 to 60% of people have some type of learning issues, and so whether it's kind of mild learning disabilities, and there's also a fairly higher percentage than the general population of intellectual disability. With autism, then it kind of gets complicated. Certainly, there probably is a higher risk of autism with NF1 as there is with kind of anybody with any neurologic disorder. Anytime there are neurologic diseases that affect the brain or um, brain injury, things like strokes or other things, that there is a higher risk of autism. But specifically, I think it's harder to speak about any specific increased risk of autism with NF1 compared to other neurologic or genetic disorders. Um, and I think they're okay. Yeah.
Yeah, I actually have questioned myself to Dr. Christensen, and thank you so much. Wonderful presentation. What we have seen, like with IVF, despite the technological changes, there's still issues with accessibility, insurance coverage and state regulations. What do we do to ensure not just the IVF part, but that the patients make it, uneventful, pregnancy? Have you seen like a more complications in NF1 and NF2 after IVF? In NF1 or NF2, that's more related, have you seen it more compared to the general public?
Yeah, so in my experience, and I've had a few patients with NF that have undergone IVF with PGT. They've had successful pregnancies. They weren't necessarily considered high risk, but we did have maternal fetal medicine see them for consultation before pregnancy, and then they followed them during their pregnancy as well. But no one had any complications, and they were able to have healthy pregnancies.
Great to know. Thank you. Thank you so much. The other to Dr. Soni, you mentioned the advances in facial reanimation surgery, the multidisciplinary approach with ENT and plastic. So for our patient with neurofibromatosis type 2 who had facial weakness either because of tumor involvement or complications, what are the approach, like when is the perfect time to intervene for the facial reanimation procedure?
Yeah, that's a good question. It depends. It varies. That's the heart of the answer. But in some cases, if there may be some transient or temporary weakness to the facial nerve, those may be cases where we wait even 6 months to a year to see how much that facial nerve will improve with time. If there is thought to be other injury to the facial nerve, such as a facial schwannoma that was resected, we know there's a lower chance that the facial nerve may improve. Those may be cases where either we perform a reanimation surgery immediately after, within a few weeks, or after the patient recovers from a primary surgery. And in some cases, we may even, if the patient has lost facial nerve function before the tumor is even treated, perform a facial reanimation first and then resect the tumor, for example, or at the same time. And so it kind of depends on what the probability of recovery of the facial nerve function would be.
Excellent. We're really thankful for all the expertise that we have here at Cleveland Clinic, each and one of you and your colleagues. And thank you so much. I see a question about the mirdametinib medication. So it's a MEK inhibitor. It's a targeted treatment. It's has been studied in a study called RENEW that led to the FDA approval in February of this year for adults and children that have plexiform neurofibroma not amenable to surgery. And it did show that the drug is effective in shrinking the tumor, as well as improving the pain, range of motion, overall functionality. So. There's a question about the diagnostic criteria for NF2 and schwannomatosis. There has not been new updates since 2022 in terms of the schwannomatosis classification, but it's I would say it's a growing knowledge, and the more we, as you see, like 10 years ago, things were, NF1 was called NF2, vice versa. As we learn more about the genetic molecular background, we're doing more testing, we're diagnosing patients earlier. That may change in the future as well. And that is the foundation for, therapeutic development. The more you know about what leads to tumors, the better you know how to target them and to treat them. So, great question.
The next question, does NF affect driving for people with NF1? My young adult child with NF1 is having problems with learning how to drive. This is an issue that kind of run into not only with NF1, but I have other patients who have other neurologic disorders associated with learning disabilities like spina bifida. And sometimes there are some motor issues, but sometimes there are also some cognitive issues. So, as we were talking about with NF1, the majority of patients do have some type of cognitive or learning issue. And so sometimes with learning how to drive, it's fairly complicated. You have to there's a bit motor planning, there's anticipation and things like that. And so, specifically, with each individual, like for this person's particular problems, I don't know exactly what the specific problems may be, but sometimes there are some complicated cognitive, attentional issues that may be obstacles in people learning how to drive, and it's not that easy. So yeah, that's something we commonly run across, not only with NF1, but other neurologic disorders.
There was a question earlier.
Okay.
I think there was a question earlier about the pain rehabilitation services. A lot of times, patients may go to providers in the community. They get a runaround. They hear from multiple providers, oh, these tumors are benign. Why are you having pain? So I wonder, how do you approach this, kind of multidisciplinary pain management where you have a parallel pain rehabilitation services ongoing with what you do, either medical or interventional?
Great question, and this is what we hear actually quite frequently in a lot of complicated cases, whether it's neurologic or otherwise. And so the stepwise pattern is very simple, thankfully. The first is validation. The first thing I tell patients, again, I've been doing this for a little while, I've not found someone to make up their pain. And if I don't understand where the pain's coming from, it's not on the patient. It's up to me, right? Why haven't I found out why they're in pain? And so I let them know whether or not we can find where the pain is coming from. We believe it's real. Let's try to, in a very systematic way, address that. And so again, we work with the biomedical. Again, I'm a pain management physician by training. So we talk about self-care, medications, possible injections. But then we also assess how is the pain affecting quality of life, mood, sleep, function. Oftentimes, when I ask patients about their pain, I'll learn more about that than where the pain is actually coming from or how bad it is. And so that's where my team of pain psychologists, pain psychiatrists, physical therapists, occupational therapists will work with the patient to help them first understand pain, learn how to deal with pain flares, and then slowly but incrementally get a better quality of life. As I like to say, everyone, especially with chronic pain, everyone hopes it's a sprint. Unfortunately, it's a marathon. But in pain rehabilitation programs, we're equipped to train you for that marathon. So it's one step at a time. But again, validation, listening, making plans are all essential.
Great. And the next question also for you, Dr. Tonka, about spinal cord stimulators for pain.
Absolutely. Spinal cord stimulation has been around for many decades. The understanding, not to oversimplify, pain is an electrical signal that goes from somewhere in the body up to the brain. Spinal cord stimulation theoretically scrambles that signal. Is there complete pain relief? Not necessarily, but there can be a decrease. In appropriately selected patients with pain going down the arms, pain in the back, maybe pain down the legs, this might be a good option. There has been a study published recently that questions the long-term effectiveness of spinal cord stimulation. So I have that conversation with patients as well. We don't have predictive ways of telling you whether 3 years from now it still works, but depending on the severity now, what else you've exhausted, it may be an option. But in the right hands, it's a very safe option.
Okay, great. Thank you. Next question for Dr. Christensen. When can a genetic mutation occur during pregnancy? And then there was another question about, can ultrasound cause, those problems? So
I'll start with the second question. So there's no evidence that an ultrasound, whether it's an ultrasound during pregnancy, or during fertility treatment, but during pregnancy, would cause a genetic mutation. So most genetic mutations are going to occur either at the level of the sperm or the egg. And so that would be where there may be the mutation. And then when the embryo develops and fertilization happens, there could be some early mutations form, but it's thought that most of them is either going to be the level of the egg or the sperm.
great. Thank you. And then there was another question. How long do patients that have to take medicines like Gomekli and the others used for NF1 or NF2, how long do they have to take those medicines?
Okay, sure. So that's a great question. So the studies that showed the drug efficacy were run for 2 years. So that's what initially we discussed with the patient, that as long as there is a response, not just on imaging, but by improvement in quality of life and pain, then we continue for a total of 2 years. What I have seen from personal experience that sometime when we stop this medication, tumors may regrow, although that's not confirmed by publication yet. So even if we stop the medication after 2 years, we still follow closely. And we may reintroduce the drug at a later point if a tumor regrowth is confirmed. But we typically, everything is really judged by the clinical, picture, not the scans. So it all depends on rate of growth, how the patient is doing, what kind of symptoms they're experiencing. But the average is about 2 years. There is another question also about medication. So 17-year-old with NF1 and seizures, questionable glioma, are both selumetinib and mirdametinib similarly effective in treating glioma found within the brain? And the answer is no. So none of them is approved for brain tumors yet. So selumetinib is currently in a phase 3 trial. So that's looking at selumetinib versus systemic chemotherapy in folks with NF1 and glioma up to the age of 22. So the fact it made it to the phase 3, that's reassuring. That means it's close to the finish line, and if it does what it's supposed to do, it gets FDA approval for that indication. Mirdametinib is in a smaller study, not a phase 3 at St. Jude. But so far, we don't have a whole lot of result about does the drug get to the brain in enough concentration to shrink these tumors. So none of them are approved, but selumetinib is closer to the finish line.
Let me try to answer this next question. It's a little bit unclear what the question was, but it said something about, should a baby consider a biopsy after a negative genetic test? So specifically for something like NF1, the genetic testing is not always 100% conclusive. And so sometimes there are mutations that are not known about. Sometimes there are variants of unknown significance. So, there's clinical criteria that is very useful for both NF1 and NF2. And sometimes we rely on that clinical criteria when the genetic test results are inconclusive. Usually we don't end up going toward biopsy, but sometimes we follow these patients over time. So with NF1 especially, some patients are born with the cafe au lait spots, these kind of dark pigmented spots that they're born with, but they don't develop some of the other findings like the axillary freckling, or neurofibromas, or the Lish nodules until a few years or several years later. And so sometimes we do have to follow them clinically. There was another question, and it might be harder to answer. I'll throw it out to anybody who might be willing to take a crack at it. Have GI issues such as pelvic floor dysfunction or transit issues due to nerve damage been seen in many patients with neurofibromatosis? So I don't know if anybody is able to answer that question or has any insight.
I think it all depends on the tumor location. So if there's a large plexiform neurofibroma, it can cause issues depending again on rate of growth. Again, discussion with the provider and appropriate imaging is very important. There's a question about the support group for NF1 and NF2. We do have support group through our brain tumor center for patients. So NF1 and NF2, there are resources in the Children Tumor Foundation, through Children Tumor Foundation, Shine a Light Walk. So yes, there are support groups. Dr. Christensen, do you think that with the advance in technology, the cost for IVF will come down, or?
I think that what will really help with accessibility to IVF is really like state mandates. And so, insurers deciding to cover IVF. And I'm finding that more and more are covering IVF. And so I think that will help. But I do think that we are seeing a decrease in the price of some of the genetic testing. So I have seen that in recent years. And so I do think it will become more affordable. But it's the genetic testing is just one component. It's like IVF in and of itself that's also quite expensive. And hopefully, what we can hope for is more and more insurers covering.
Thank you. And Dr. Dewan, with the gene editing, sure you're aware about the study in China with the NF2. Again, it's very early to comment on success for that. But despite the challenges of bringing this to humans, as you mentioned, there is hope. So do you think that time frame wise, based on the technological advances, the rate of how things are moving across the pipeline, this is something we're going to see in the near future in the US?
Yeah, it's a very good question, Dr. Lovas. I think we're getting closer. I won't give you a number because I've learned I'm always wrong. But I mean, to be fair, the fact that we have a published case now of a rare tumor in a patient-specific therapy developed, approved with like the investigational drug by the FDA within 8 months is extremely impressive. And so I think, that can't be replicated for every single patient at this point. We don't have that scale or capability, but that's the roadmap, right? So you think about, there's a couple hundred researchers in the US like myself who are working on this day and night, 7,000 genetic diseases to go. So, and there's people around the world also collaborating with us. So I do think progress is going to accelerate. I just don't know when, but I think we're at that point now where we have a way forward.
Thank you so much. Do you have any other questions?
I don't see any other questions for right now. But this is a wonderful session. Lots of great information here. Lots of great questions from our audience. I want to thank you, everybody, so much for participating. A couple of things I want to remind people: you'll get an email with a link for a feedback form. So please fill out any feedback that you have, especially ideas for future sessions and future symposiums, future topics, things that you're interested in. Also remember, the Shine a Light Walk in October. I want to thank again our sponsors, the Children's Tumor Foundation, and also SpringWorks Therapeutics for their generous support for our program. I wanted to give a special thank you for our patients, Jacob and Sanchari, also for Marty Tobin and Jessica Price, who have worked for months to put this together. Thank you so much. Thank you so much to Ted for audiovisual support. Thank you. And then, I think that's it. Think of anything?
I'll add one thing.
Yes.
So May is the NF Awareness Month, but it's also the Brain Tumor Awareness Month. So we have a busy weekend. Tomorrow we have Head for the Cure at the Cleveland Metro Park Zoo. It's a 5K fun event for patients and families with brain tumors, and everyone is welcome to join and register. But can tell that for everyone here and my colleagues who care for folks with neurofibromatosis, this is dear and near to our hearts, and we really appreciate everyone sharing their weekend with us. Thank you so much.